Why? Because they want to save the vocal cords. The longer the tube is in, the more irritated the vocal cords are. So they take out the ET tube and they put in a tracheostomy tube, okay? The most common type of tracheostomy tube that you will see in the hospitals are these, either Portex or Shileys, okay, that's the brand name. Now, all of your tubes have an inner cannula and an outer cannula. Some of them, this has a lock mechanism on it and this pulls out, okay? See what yours has on it. Yep. I think yours has clips on it, right, Jovi?
Yes.
Okay, what does yours have, clips or a lock? Okay, switch tray tubes so you can see what the clip ones are, or else let me show these guys. Okay, so this is a clip one, you don't turn it. You unclip and take the inner cannula out. This one's a clip. Okay. Yeah, oh, you did, okay. See, and you clip it in, so it can't come out. Okay. Not that one you lock in. Okay, so when you change the inner cannula on these, you have to push it in and make sure the clips have clipped into the edge of the tray, okay? See this, when you squeeze the clips to take it out, you put it back and you clip. Now, this is the 15 millimeter adapter that a ventilator hooks to, or a resuscitator bag, okay? Unclip, take out. Put it back in, clip so it doesn't come out, okay? Now, trachs are made up of 3 parts, which you'll likely have to identify in a picture, okay? One is the inner cannula. One is the outer cannula. And one is the obturator, okay? So, the obturator is this thing. Okay, so I want you to take out the inner cannula, put in the obturator. Okay. All right, did everybody put the obturator in? Feel the bottom. It's smooth, right? Will yours fit in?
No.
Oh, okay, it's not here. That's a smaller tube. Hold on. All right, Jovi, I'm gonna have you look at this, only this tube is different, okay? It's got holes in there, but that's not usual, all right? That's called a different kind of trach. So the obturator is in there, all right. They make a slit between the second and third tracheal rings. They lift up the ET tube, okay? They're looking at the trachea at that point, the inside, they lift up the ET tube so that the ET tube is above the cut. And then they insert the trach. Now, if they inserted it without this obturator, these edges could get caught in tissue. This makes for an atraumatic insertion because it smooths out the end. So the trach gets put in, the second and third tracheal rings, this comes out, the inner cannula goes in. So the obturator is used to insert the trach to prevent mucosal trauma. That's all the obturator does. You will see this in a patient's room, taped. Where's your inner cannula? Did I take it? Is that it? To above the bed. Sometimes it's taped on the wall. If the trach was ever dislodged and it came out, you would take out the inner cannula, put this in, and feed the trach back in. Okay? Got it? So the obturator is used for insertion of the trach to prevent mucosal trauma. That's it. Okay? You have the inner and outer cannula. You have a cuff on there. What's the cuff for? It's just like an ET tube. If you're on positive pressure ventilation, it prevents air from going around the outside of the cuff and it directs it down into the lungs. You have a pilot balloon that is it's a spring valve in there that inflates. Everybody look at your pilot balloon real close. When we say spring valve, look at your pilot balloon. That's your pilot balloon. There's a spring in there. See it, the spring valve? When you push, a syringe on there, you push the valve in and you open it up so that you can get air in, okay? And then you take it out and the spring goes back and closes. So if you see your springs in there, does everybody see them in there? Okay, that's the spring valve pilot balloon, okay? You take air out. So what you're doing is you're pushing the spring in, put that on the outside and inflate it. Did everybody inflate their balloons on their ET tubes?
Yeah.
Did you inflate them earlier on the ET tubes that you had? There's a spring valve on the pilot balloon in those too, okay? If that spring valve does not close, it'll leak air out of the cuff. Okay, so when you push that in, if you did it before, you'll, all right? So what are the three parts to the trach? Obturator, inner cannula, outer cannula. What does the pilot balloon do? It inflates the cuff. How do you measure cuff pressure? With the cuffulator. Did Joni show you that?
Yes.
How it shows the pressure in the cuff?
No, just from the car.
Yeah, so inflate your balloons. Here, come over and get a syringe. Come over to the table, inflate your balloons. Herbie, inflate your balloon. Inflate it pretty high. Put 20 cc's in there. Everybody coming over? 20. Might not even be able to get 20 in there. Could blow the balloon. Okay, feel how hard that balloon is. You feel it? Watch. Now, when you're checking a cuff pressure, you never hold the balloon, because that's pushing more pressure. All right, watch. It's supposed to be below below 35 centimeters of pressure. What is that? It went all the way around. About 140? Okay. Every time I put this in here, it lets air out.
Wow, that's a lot.
Sure is. Okay? I could even tell you if I went next to a patient and felt that. That's too much pressure. Okay? You can also let air out by pressing this. And it lets air out of the cuff. Now that's 34 centimeters of pressure. Now there's something that we don't have yet. That's just against a tracheal wall. Now, Henry, put it in there, hold it. My hands are going to be the tracheal wall. Now what was the pressure? Here, show it so that people can see it. And keep it in there. Okay, what is the pressure? 80? Now prevent on the tracheal wall. Squeezed around that cuff. Alright, so, and that's excess pressure on the cuff. Alright, at 80 centimeters you're going to cut blood flow to little capillaries. So let air out until you get down to about 30. Yep. There. Now, that's against my hand, which is acting like the trachea. Okay? So that was sealing. So notice how it says 10. But if I was inside the trachea, my mucosa would be compressed by that. Make sense?
Mm-hmm.
That's how a cuffulator works. Okay? So now, put it in and see what the pressure is. Oh, I want you to do something else. Okay. Measure the pressure in your cuff. I'll hold this. You hold this. Now, remember how I said don't hold the pilot balloon? Because I'll show you hold it down on the hard part. Keep it there. All right, now, if I was to hold that pilot balloon, look what happens. Okay, so you want to hold in the hard part. Now if this was in my trachea, look how much pressure is exerted against the mucosa, okay? Put your hands around there. All right, now you're gonna let out air until it drops to about 30 centimeters of pressure. You keep your hands around there. You feel the cup deflating? Now, there you go. You just loosened too much.
Oh,
Have it the way you had it before. Okay. Okay, let it out till there's, all right, so you see how that cup is
yeah.
deflating?
Yeah, I see.
So you don't wanna have, so that's my tracheal wall right now. You don't wanna have that balloon compressed to any more than 35 centimeters of water pressure, which is equivalent to about 25 millimeters mercury. And that, you need the pressure in the capillary to be higher than what's in that balloon so you can get blood flow. Does that make sense, the capillator now?
Yeah.
Okay, did you wanna check your pressure? You pretend, here, I'll hold your, I want you to put your hands around that as if you're the trachea. Okay, just not squeezing, just, okay. So, I'm gonna check your pressure. Okay, I'm very high, and I'm gonna drop the pressure. Whoa. Feel the air coming out of it? Now that would be acceptable pressure against the trachea, okay? Between 30 and, below 35 centimeters of water pressure. Make sense? Okay, let's see how your balloon is. See? Okay, as compared to this. I can tell, let me see. That actually doesn't feel that tight. It's not that tight. Okay. You've got your hand squeezed around there, but what I wanted you to do was fill the balloon. You filled it. Okay, put your hand around there. Okay, not tight, but as if you were the trachea surrounding the cup. Okay, now I'm gonna take air out because it's too tight. Feel that? Okay, how much less air? Okay, so this is gonna be tight. Feel that balloon. If you go into somebody's room, feel this balloon. You know that pressure is high. Okay, you just know it, just by touching it. Okay, 120. 100. Down. Okay, there you go. All right, so hopefully you understand a capillator a little more. Make sense?
Yeah.
Okay, all right, let me put this back. Oh, yeah, okay. Did I take that? Oh, did I take it? Oh, shoot, I did?
Well, I had the one that was in your hand, and I don't know, I'm not sure.
What did I do with it?
Oh,
Where'd I get this from?
This one was mine, but this one was the one that you had. I just don't know where you had it.
Oh, okay, and you have the obturator. Do you have the inner cannula too?
Yeah. I have
Oh, okay, good, all right, okay. All right, so. Anybody see what I do with the clicker? Oh, geez. Oh, okay, all right, so. Rounded tip on the obturator, what's that for, guys? When do we use the obturators?
For prevention of insert.
On insertion to prevent mucosal trauma.
Mucosal trauma.
Okay, you've got a 15 millimeter adapter, what connects to that? Will ventilators connect to it?
Yeah.
Will bags connect to it? Okay, will a T-piece connect to it? To set up an aerosol T-piece? You have the
Yep.
standard adapter, okay? You have the outer cannula, the inner cannula. Guys, there never used to be inner cannulas on trachs. So what do you think, what's good about having an inner cannula on a trach? If they can be changed. Why would you want to be able to change it? Think about a trach that didn't have an inner cannula and one that does. A lot of secretions, dried up secretions. Could the trach plug? And if you don't have an inner cannula and that trach plugs, you gotta take that trach out of the patient, where the physician does, in an emergency, okay? This way you just pull out the inner cannula and put in a new inner cannula. And it's part of the trach here, Okay? All right. Okay, so why would people need a trach? Long-term intubation, okay? Someone who doesn't need a vent anymore, but can't keep their secretions, can't handle their secretions, doesn't cough well, then the trach, okay? Or to bypass an obstruction in the upper airway, an emergency trach would have to be done. So when we're weaning somebody off the ventilator, once we get them off, let's say they've been on the vent a long time, okay, so they're trached, the question comes, can we take the trach out? Well, they have to be able to cough, they have to be able to manage their secretions, and they have to be able to swallow without aspirating, okay? And then if they can do all those things, you take the trach out. All right, so what's the good thing about a trach? Well, you can talk with certain trachs, all right? That doesn't mean all trachs, you can talk with certain trachs. If you have a good swallow and you're not on mechanical ventilation, you can eat, all right? There's less airway resistance because the ET tube is very long, okay? And it's easier to tolerate than an ET tube. Why? Because it's not in your mouth and it's not in your nose, okay? All right, so, okay, the obturator, we already said what it was. Inner cannula, we already talked about what that was, okay? If it's non-disposable, the inner cannula, then you have to clean it. You take the inner cannula out. There's trach cleaning kits that have little brushes, and you use half hydrogen peroxide and half sterile water. Have you ever done that, Jovi? Trach care? Okay, you mix half hydrogen peroxide and sterile water, and you clean out the trach, and you take a brush and you clean out, it's like cleaning out a straw, permanent straws. Okay? Does anybody have permanent straws now instead of the plastic ones? I bought them and my mother's like, what is this? I said, it's good for the environment, Mom. Okay, all right, so now, those are Portex, Shiley's, regular trachs. There's a few trachs that are special trachs that you guys need to know about. And the first one is a fenestrated trach. All right, put your trachs back together with the inner cannula in them. I'll take the well, no, I won't take the operators yet. And then I want you to look at what is the difference between this trach and that trach. You guys can take these two, okay? And show your partner yours if it's not the same. Look all around that trach, and what is the difference in that trach?
The
It's called
size?
a fenestrated trach. You see fenestrations. What are fenestrations? Holes, like a fenestrated capillary. There's holes in that one. Now take out your inner cannula. Is there a hole in the inner cannula?
Oh, yeah.
Yes and no. Some
Yes.
no, some yes. Okay? All right. What's the purpose of a fenestrated trach? Okay, let me see that fenestrated trach. Okay, yours has a hole in it. All right. Who has ones with holes?
Okay.
With holes. Does yours have holes?
Yeah.
Yours has a hole on the inner cannula?
Yeah.
Okay.
Both of them.
Both of them? Does yours have hole on yours?
Yeah, it does.
Both of them or just the outside?
It doesn't have the inside part.
It doesn't
Your
have inner cannula.
fenestrated trach doesn't?
No.
Oh, does
It
your
doesn't
other
have
one
inner
fit?
cannula.
Here. Okay, let me see if this fits. There you go. No, that doesn't fit. Okay. All right, so here you go. Okay. Inner cannula. That has a hole. Okay. What's the purpose behind the fenestrated trachs? Okay. These are used on people, whoops. Okay. The fenestrated trach are used on people with, who may be off the ventilator during the day, but they have to go on the ventilator at night. And a fenestrated trach tube will allow them to get used to using both their upper airway and the trach site. It will allow them to talk, okay? And they can eat if they can swallow. So, you're on the vent all night. You need to be able to go on the vent and not cause a big leak. So the type of fenestrated trach you would want is the fenestration's on the outside, but the inner cannula is not fenestrated. So, Jovi, you have one that's not fenestrated, right? Okay, so hold that up. She's got a regular inner cannula. So if Jovi's patient is off the vent during the day, you would take out the inner cannula and you would put in one of these little plugs, okay? I'll show you what that looks like. I don't know if this is gonna fit on that. Does that have a clip? I don't think, oh, there we go. Okay, so when the patient breathes in, okay, if you had the plug on there, they had the trach and the plug on there, they're breathing in through their mouth and air goes out through their mouth. Because this is plugged, they can also talk because they can use their vocal cords, all right? At night, when they have to go back on the vent, you take the plug out, you put the inner cannula without the hole back in, and you inflate the cuff. Okay? Everybody with me? Because that plug won't allow you to breathe through here. Okay? Now, it can also be used on patients, okay? Here's the thing. Well, let me go through this. So you come in the morning, Jovi's had the patient all night long, and Patea comes in the morning, and he's going to put the patient on a nasal cannula. So he has to take the patient off the vent, and he has to plug the trach. All right? So he's looking at the patient. Patient's on the vent. He says, how am I going to do this? All right. So the first thing you want to do is suction the patient. Okay? So you suction the patient, get the airway all cleared out, suction out the mouth. Then, do you deflate the cuff before you put the plug on? So if the cuff was up and the plug was in, when they went to breathe in, where would the air go?
Through the mouth? No.
They can't get around the cuff.
Oh, yeah.
They wouldn't be able to breathe. So it's a stepwise fashion. You suction the trach and suction out the mouth. You deflate the cuff. So you suction first so that when you deflate the cuff, all the secretions don't go down, right? So you suction, you deflate the cuff, you take the inner cannula out, and then you plug the trach. So the trick is going to be on an exam to understand there has to be a way to do this. Suction, deflate the cuff. Never put the plug on there until the cuff's deflated. Okay, because then they won't be able to breathe. Got it? Okay. All right, so let's look at the PowerPoint. Okay? So the outer cannula has a fenestration. Everybody point to the fenestration. Outer cannula has a fenestration. That's why it's called a fenestrated trach. Okay, everybody's got that? All right, the outer cannula has, or a window. Okay, some people don't have little holes, some people have windows. Who has a window? Okay, Demi has a window. Demi Lowell has a window, okay? All right, it's used to facilitate weaning from a trach tube or from the ventilator. How do we do this? It gets them used to using their upper airway, which they haven't used in a long time. Because with a trach, air goes in through the trach and out through the trach. When you button them, air goes in and out through the upper airway, okay? All right, if you don't button them, they'll use both upper and lower airway if the cuff is deflated. So, during the day when the patient's off mechanical ventilation, the inner cannula is removed, the cuff is deflated, and the red button is put on the trach, okay? So again, what do you do first? suction.
Suctioning.
Do you ever put, if you list the button goes on and then deflate the cuff afterwards, oh boy, that's gonna be wrong. Suction, deflate the cuff, button on. With that button on, what are they using, guys? Upper airway. They're using their nose and their mouth to breathe. Can they talk when the button's on? You'll see people hold their finger over their trach if the cuff is down, because one of the first things you want to do in the hospital when somebody's weaning off mechanical ventilation and during the day they're off, the doctors will say, let's drop the cuff. Okay, see if they tolerate that. If your patient starts coughing and a lot of secretions are coming up that look clear and white, their swallow mechanism's been impacted by being trached. They can't swallow, so they're aspirating their saliva constantly, all right? If they're not doing that and they're swallowing well, you leave the cuff down during the day, they'll put their finger over the trach tube and they'll talk to you, okay? Because then it forces the air up on exhalation through the vocal cords and they vibrate and then they can make noise. Does that make sense to everybody? Okay, all right. So we use these when to facilitate weaning from the ventilator, allow the patient to talk during the day. It doesn't make you wean any better. It just says if the patient's off the ventilator during the day and they have a fenestrated trach tube in, plug it, get them used to using the upper airway, let them talk, okay? If they don't have a fenestrated trach tube in it, it's a regular trach, we drop the cuff during the day and let them use their upper and lower airway, okay? Okay, so here's when you're using one of these, again, suction above the cuff, deflate the cuff, remove the inner cannula, plug the trach. That's the steps, okay? All right, if the patient needs to go back on mechanical ventilation, what do you have to do? So, you put the patient, you plug them during the day, you get a call at 3 o'clock, the patient's not doing well. You go upstairs, you decide they need to go back on the vent. What do?
Suctioning first?
You're
no,
putting
no,
them back on.
Inflate the cuff. Take
You got
out
that plug on the outside.
Yeah.
Take the plug out.
Take a plug out.
What are you gonna do? Put the inner cannula in, reverse the steps.
Okay.
Take the plug out, put the inner cannula in, inflate the cuff, and put them back on the vent.
Okay.
Got it? Okay.
Do we have to do suctioning on that?
No, not unless
No.
they have secretions.
Okay.
But you definitely have to do it before you drop the cuff, because people have saliva and stuff, it drops down
Okay.
there, and as soon as you drop a cuff in somebody, they're coughing, and then there you go, introduce VAPS. Okay? All right, so with the cuff up, air is going in and the inner cannula in. You have a cuff up, inner cannula in. The air is going into the trach, any trach, and it's going down into the lungs and it comes out the trach. The second picture, okay, you have a regular trach with the cuff down. They breathe in through the trach and it'll also go in through their mouth if the cuff is down. And then they're using both the upper and lower airway when you drop the cuff. If you've got a fenestrated trach with the cuff down, all right, you've got much more airflow because that elbow now has a hole in it.
Mm-hmm.
So they inhale through both ways and exhale. If you have the plug on the outside, they use totally the upper airway. Does it make sense to everybody? I know you guys are sitting here listening to me, but does it make sense?
Yeah.
Yeah, okay, all right. So the fenestrated trach, if I say what's the indication, it's facilitating weaning so that during the day the patient can be off the vent, they can talk, they can use their upper airway, okay? All right, metal trachs, guys, these have a tendency to be permanent trachs. Want to put all your fenestrated trachs back together and your regular trachs back together? Come up, and I have 3 boxes that say regular trachs. Put 2 in each box. This is for regular trachs, okay? Put them all together. And then fenestrated trachs.
Oh, so
My orange boxes here are for fenestrated trachs, and then put the little yellow, the red things in there. Fenestrated, yeah, just put them in one of those 2. 2 or 3 in each box. Huh? Oh, put them in the trach boxes. Oh, I have you know what, I have one that wasn't right. What is this? This is not right. Regular, yep, regular trachs in here, okay? Got them? Here, or is that a regular trach or fenestrated? No, that's fenestrated. No, it's got a hole. Fenestrated going here. Okay? Fenestrated. No, I mean, wait a minute, regular, this is a regular trach. Guys, you're screwing me up. Regulars going here. Make sure those are all regular trachs in there. The orange boxes are fenestrated. Henry,
Yeah.
is that one? That's fenestrated. Fenestrated? Do one of them not have an intercannula? Oh, they all have. Somehow I got messed up here. Okay. Oh, here we go. That's a regular. Oh, regular. Tomorrow I'm gonna shoot myself in the lab if I'm going crazy. I got one that's, okay, 3 regular. I'm missing a regular. Didn't each one of you have a regular? There it is. Okay, all right. Okay. All right. I have 3 Jackson trachs, so I want you to sit together. These are permanent trachs, okay, for people that need to have a trach but don't need a cuff. All right, so, okay, what's missing on those?
Intubator.
Huh?
Intubator.
The what?
Intubator, is it?
The cuffs or the obturator?
Intubator.
They do have obturators.
Oh, they do?
Okay, they do, for insertion. All right, they have obturators, but there's no cuffs on those, right? And there's no pilot balloons. So can you put somebody on a ventilator who has one of these in?
Yeah.
No. Where's the positive pressure gonna go?
Oh, yeah.
You need a seal. So if somebody with a permanent trach has to go on a vent, what do you need to do? Take out the permanent trach, put in a regular trach with a balloon, all right? So, you guys are gonna be going in patients' rooms. If you have to do the cleaning of the trach, you need to figure out how to get the inner cannula out. You twist until there's a little depression. Everybody take out your inner cannula. See that little depression?
Got it,
Okay, when
right?
that goes back
You got it,
in,
right?
the problem is when people put them back in, they don't lock them, and then they fall out. Practice that. You see where the depression is? Yup. Now pull it out. Right, so people put them back in and they don't turn them. Okay, and the inner cannula falls out. Got it? Okay, now, you cannot put, how would you bag somebody with those? You can't do it. So what you have to do is find a little adapter, and usually they have these in hospitals, specific adapters that are sized, but if you're really hard up for an adapter, pull one off the end of an ET tube that will fit down there, so you can at least give the patient 100% oxygen. This is not gonna be a perfect fit, because this is a wide one, okay? But that's how you would do it, and you would attach those to the bag. Because you couldn't attach a bag on there, okay?
So we don't need the inner cannula.
Yeah, you do.
I mean the other one, the bubble, the bubble one.
The bubble,
Yeah.
the cuff.
The cup, yeah.
Yeah. No, because these people are not on ventilators, they just need a permanent trach, okay?
Okay.
So these are metal trachs, they don't rust. Permanent trachs used in people that need a permanent trach, for some reason, maybe they had cancer, okay? There's what we call laryngectomy tubes, but that's at the end of this. But you'll see some people come in with permanent trachs, metal trachs. So they have obturators, okay, if in case there was ever, so in other words, when the trach is put in, the inner cannula is not in there, okay, the obturator goes in. So it slides into the space, okay? Inner cannula goes in, and it stays in, okay? Now the inner cannula, it gets washed. They have trach care kits that have little brushes and peroxide in them. You mix equal parts peroxide and sterile water. You put this in, clean it out, clean out the inner cannula, rinse with sterile water, and then you put the inner cannula back in the patient, okay? All right, so that's a metal trach. So the metal trachs have 3 parts, just like all the other trachs: obturator, inner cannula, and an outer cannula. There's no cuff, they're cuffless. Did you guys see what I did? Oh, cuffless, okay? And you need the 15mm adapter. If you're gonna bag somebody, that's the little adapter I put in from the outside so that you can connect a bag. And they're used in patients when weaning them from tracheostomy tubes. A lot of times what they'll do is they'll take the plastic trach out and they'll start downsizing and putting smaller and smaller trachs that don't have cuffs, and eventually they take the trach out, okay? All right, or those that need long-term ventilation but are not on a ventilator for positive pressure ventilation, okay? All right, so the next one is a foam cuff. Can you guys come up here? All right,
Foam cuff.
foam cuff. So, these, everybody feel that cuff? Is that nice? What's nice about these is that they form to the trachea. Now, when I first came out of school and worked at the hospital center, nobody ever taught me about foam cuffs. And I went in there, and I am trying to figure out how to measure pressure. Number 1, you can't. How to put air in the cuff. Number 2, you can't. Number 3, I'm like, why is this open? So I closed it. Not good. All right? So, the way these work is that this, in other words, when I'm inserting it, I have to take the air out of this sponge. So I put it in the patient, physician puts it in, I'm sure there's an operator on these, get it in, and then he undoes this, and this must be left open to the atmosphere, because this cuff does not take air. It just inflates with atmospheric pressure until it seals the trachea. So, it must be left open. Because if you had this in here, eventually, it's going to deflate. So, when you have this cuff in, if you were going to remove this trach, you have to take out the air. But it inflates by the pilot being, this is the pilot, being left open to the atmosphere. So, if you're not having to put air in this, you don't have the chance that you're going to put too much air in and cause too much pressure on tracheal mucosa. This just inflates until it actually seals the trachea. And there is not damage that can be caused from a cuff that you actually push air into. Got it? That's a foam cuff, okay? So this one, same thing. So foam cuffs, you're less of a chance of causing any tracheal trauma. Now what I have to do is, as soon as I pull this off, I have to squeeze this, or I won't be able, or it'll start to inflate again, okay? I'll let you guys try it. Because if you don't squeeze it, it's open to atmospheric pressure. Okay, so trach is like this, okay? So goes into the patient, and then you leave the pilot balloon open to atmospheric pressure, and it will inflate until it seals the walls of the trachea. So you don't have the problem with high pressures, people coming in, putting more air in the cuffs, not sure what they're doing, okay? And this thing is just sealing nicely and doesn't damage the trachea. Okay, so you guys Try taking air out. So that's a foam cuff. Very nice for not causing trauma. But that red thing has to be open to the atmosphere. So okay, so Henry, are you squeezing that? You don't want to squeeze it. Go ahead, pull the air out. Now before you disconnect the syringe, you have to squeeze that, because if you don't squeeze it, what's going to happen? It's going to inflate again. All right, now pull more air out because you have to totally deflate it. So you see what you're doing there? Unsqueeze. Here, you guys try it here. Because until you do it, you don't know what you're doing. Whoever wants to do it. So you want to get that totally down. So you have to keep it squeezed. There you go. So in most cases, guys, some hospitals that have a little more money, there you go. Now open it to room air. They might have fenestrated trays that they put in patients, but at hospital center we don't. It's usually somebody's transported and brought to the hospital and they have a fenestrated trach and they're coming from another hospital. Because they're likely expensive. Are you able to do it, Demi Lola? It's filling because you're not squeezing that red pilot balloon enough once you disconnect the... You see what you might be doing wrong? Don't squeeze it until you there you go. Until you disconnect. Did you get all the air out? Did you?
Yeah.
Okay. Yeah, you have to squeeze that thing closed once you disconnect the syringe. Well, you are not deflated yet. Make sure you deflate it all. Oh, see? You let it go. That's the thing. There you go. So you have to keep deflating, but when you disconnect the syringe, you have to squeeze that red thing. Does anybody live in DC? Here? Nobody lives in DC? Boy, is that locked down. We need to keep President Biden safe. Okay. Did you get it all out, or you still have more in there? There's a little more in there, but now when you let it open, it'll inflate. Got it? So a lot of air fit. I'll tell you what, those ET tubes, did you see how much air can fit in those cups? Okay, it's like you could put 40 cc's in those, but that's not how much you need to seal a trachea. It's usually about 10, and then then you have to check the pressure. Okay? All right. So make sense? Go to your lab books and find the fenestrated trach for me, find the metal trach, and find the foam cup. Let's see if you guys can find it. Find the metal trach first, and then hold it up. Did you find them?
Yeah.
Metal tray? Okay, and the 3 parts? Great. Find the foam cup. Find the trach that has a foam cup. Tracheostomy tube. You bet. Let's see. Is that a tracheostomy tube? Yup. No, look yourselves. Yup.
Yeah. Right?
You're looking for the foam cup, trach tube. The one you just looked at. Did you find it? Let me see.
Yeah, there's the phone call right there.
Yep, got it?
No, the
Okay.
phone call. Yeah, yeah. That's
Okay, you're looking for the king tube.
Huh?
King tube.
T2. This is it right there?
This one,
Yeah.
Yep. yep. King, yep. King does, yep. Yep, Tommy tube.
Huh?
The combi tube,
Combi-
combination
combi tube.
tracheal esophageal, yep.
What?
Combination tracheal esophageal tube. 1 and 2.
Oh, yeah.
Yep.
Combi-
Right, we got it? Everybody got it? Yep, yep. Yep, did you find it? Yep, okay, alright, and, I don't think the, Carlin's tube is on there, is it? The Carlin's tube? That's for independent lung ventilation? No? Okay, how about the LMA? Laryngeal mask airway,
This is the one?
laryngeal mask. Yep, laryngeal mask, yep, okay, we doing good? Okay, alright, so we got the foam cup, so that yellow thing has to be, true or false, yellow thing's gotta be, yellow balloon, pilot balloon's gotta be closed.
What?
True or false? The red pilot balloon red pilot balloon on these, foam puff needs to be closed. False. If you close it, the balloon can't inflate.
Oh, okay.
Alright, okay. Alright, let's see. Okay, so this is your foam cuff, alright? Alright, now, in the ICUs, we have noticed sometimes with patients that we're ventilating, no matter what we do, the cuff, we got a leak. And people are putting higher and higher pressure in. What they found out that there is abnormalities that require either trachs that are extra long distally or extra long proximally. So, if somebody has a very large neck or a bull neck, a lot of adipose tissue, and a regular trach is not sealing, we give them a trach tube, which is an extra long, proximal tube. Hold on. Proximal. So, you look at the elbow, okay? This is what a trach normally looks like. Okay, I know this is fenestrated. From here to here is longer. See how you started the elbow right here? From here to here is not that long. From here to here is longer. See the difference? To the elbow. Here to here is long. Okay, so pass that around. That is an extra long proximal. So if there's a lot of adipose tissue and you have a leak with a regular trach tube, you need to suggest an extra long proximal tube. Okay, this is a distal. All right, extra long distal. Okay. Proximal. Got it? All right, did everybody get to see that? From here to here, on this one is normal size, okay? See that? So that will go through, if somebody has a very fat or bull neck, the curvature does not happen when it's close to the adipose tissue, because those trachs can dislodge. Now this one, so this is an extra long proximal. This one is not long from here to here. Look at the difference. This one is longer from here to here. See where the elbow is? If you have somebody that has developed some tracheal anomaly where we can't seal the cuff anymore, or if they're extremely tall for some reason and it's not working well with the tube we have, we put in other words, it's leaking. No matter what, we're losing volume on the machine, we're getting a leak, they try the extra long distal. So extra long distal means it's longer from the elbow down to the end of the trach tube. Extra long proximal is from the flange to the elbow. okay? So the proximal would be used with somebody who is leaking constantly. That's the only time you would consider these guys. If you have a major leak and they're concerned and your pressures are getting higher and higher in the cuff, you say, you know what, you can obviously see this is a large person. We may need an extra long proximal. They have to be specially ordered. They're more expensive. They put that in, the leak goes away, you no longer have problems. Also true if somebody has some sort of tracheal anomaly and you feel you need a longer trach, then you would get the extra long distal. Make sense? That's the only thing that's different on these tubes. So, extra long trach tubes. We have the XL proximal used with people with a thick neck, XL distal if there's an abnormality in the trachea. So you can see this one is long. This is the extra long proximal. From here to here to the elbow is much longer, okay? Here, this is much longer from here down to here, okay? So you would only think about those if you're a therapist, you're on the, you're in the ICU. It's the physician that needs to know from you, no matter what I do, I can't seal this cuff, I'm losing volume, patient has a very large neck, maybe we should try an extra long proximal tube, okay? Or if you have someone, if you push the trach in just a little bit, it seals, okay? Very tall, thin person, or somebody that may have some abnormality here, you say, you know what, maybe we need to try an extra long distal. The residents and therapists will not know, the residents will not know, and physicians, there's a problem unless you tell them. And it's usually, with you guys noticing high pressures, no seal, you can't keep a good seal and things are leaking, okay? All right. Okay. Whoops. Okay. Bovona TTS, okay. If you go to the University of Maryland, there's something called a Bovona TTS. TTS is tight to the shaft. So when these, in other words, this is the shaft of the trach. When the cuff is deflated, you can barely see it, all right? It's so tight to the trach. These things don't get inflated with air. They get inflated with sterile water because those cuffs are made with silicone. So if you put air in them, the air will leak out. TTS trachs, tight to the shaft trachs, they're special Bovona trachs. They've been used up in University of Maryland, and students will do case presentations, and we'll talk about these trachs, and we'll talk about trachs that instead of air going in, they put sterile water in. So when I ask them, well, why do you put sterile water in? They don't know. It's because if they put air in that silicone cuff, the air will just leak out of that. It'll diffuse out of the cuff, okay? So these are special trachs designed so that when the cuff is deflated, there is the minimal amount of resistance around that tube. Because you can see when I deflate this, okay, I deflate this, but it doesn't really go flush against the trach. See all the wrinkles?
Mm-hmm.
All right, when you deflate these, you can barely see that balloon. It's flat against here, so there's no resistance around that, okay? So those you'll see at University of Maryland. I've never seen them at hospital center. Okay. All right. They have high flexibility. I don't even have one of those to show you. Cuff pressure can't be measured because, again, the pilot's filled with sterile water, okay? And why do we fill with sterile water? Huh? Because why can't you put air in those cuffs?
It's silicone.
It leaks out because it's made with silicone, okay? But the thing with silicone is it just collapses really, really nice around that trach. So there's no resistance to somebody with who is trying to breathe around that when they're not on a ventilator. Okay, so what do you need to know here with insertion? They're put in between the second and third tracheal rings, okay? They can be done in the OR under sterile conditions or at the bedside. You guys won't be in the OR when somebody's trach, but now they're doing a lot of trachs at bedside. They're called percutaneous trachs. I'll teach you more about that in trends, but that is put in a little differently than in the OR when they cut and dissect the trachea. They don't quite do it the same, all right? But the entrance is between the second and third tracheal rings. Question on the boards is, as the trach is going in, when is the ET tube pulled out? The ET tube pulled out is when the end of the trach is visualized in the trachea, then you pull the ET tube out, okay? Okay, so complications, when they first put in a trach tube, of course bleeding, the first 24 hours. When a trach is put in, the surgeon comes around the next day, and he says, any trouble with the trach? He's wondering, how's the bleeding look? Was there a pneumothorax? Is there any subcutaneous air around the site? So it's nursing and RTs that will look at that as part of your airway care when somebody comes back with a fresh trach, okay? Air embolism is rare, but that can occur. Late stages, meaning after 24 hours, of course it's a cut, you can get an infection at the site, you can have an excessive amount of bleeding, the trach can obstruct. That balloon, if the pressures are high on that for days and days, can cause a hole between the trachea and the esophagus. You get a fistula, okay? The management, cuffs should be deflated unless the patient's on positive pressure ventilation, all right? But if they can't swallow, then it's gonna have to be up because they're gonna aspirate their saliva. They do daily trach care and clean them and stoma care. The boards like to know if you know how to clean them. Here's the key. You clean them, I told you, a half and half solution of hydrogen peroxide and sterile water. You use a Q-tip. In other words, you undo the trach ties or what's securing the trach. Usually they're stitched in place on the sides, but there's also trach ties. So you dip a Q-tip in this solution and you don't wipe back and forth. You wipe away from the stoma on one side, get a fresh Q-tip, away from the stoma on the other side. The hydrogen peroxide and sterile water is to clean the site, okay? And then you put in, if you have to, new trach sponge or trach ties, okay, to keep everything clean. So never wipe back and forth, and the boards will ask you, what's the percentage solution? It's hydrogen peroxide, 50%, hydrogen peroxide, 50% sterile water. All right, stoma care, I just talked about that with the Q-tip, okay? Okay, so the boards also like to say, what would you do if you found out the patient had an obstructive trach? Well, on the boards, there's no doctor. You're the doctor. What do? You take out the trach, okay? You take out the trach, and if you can't pass a suction catheter, you take out the trach tube and then manually ventilate nose-mouth. If you have super high cuff pressures, the reason is usually the trach tube is too small. You replace the trach with a larger tube. Okay, if you're inserting air into the pilot balloon and nothing is happening, and you're still leaking, you have a ruptured cuff. You take out the trach and replace it with a new one. Okay?
Are you finished?
Yep, just about.
Good. This
Okay.
is for you, and then I have papers to hand out to them.
Oh, I have the, okay,
I'll print
one
it out
second.
for you.
Okay, so when is somebody ready to have a trach tube taken out? When they're able to cough and clear their secretions, and they also must be able to swallow, okay? Because once you've had these balloons in you for a while and they're up, and there's also the trachea or the esophagus, the muscles don't quite work right anymore and people have trouble swallowing. So they do what they call a barium swallow study. So they, oh no, this is not a barium swallow, sorry. This is bedside. They'll come with either a little, first they'll start with ice chips. They'll give them ice chips and they'll see if they swallow. If they swallow and start coughing, are they aspirating the ice chips? If you give somebody ice chips in their mouth, the cuff is down, and you tell them to swallow, and then they start coughing. Was the swallow mechanism working? No. Sometimes they give them cherry jello or strawberry jello, and they'll give a little bit, put it in, give it, and all of a sudden they start coughing and they suction out the trach and they're getting red stuff coming out the trach. That means they're not swallowing, so you can't take the trach out, okay? So they have to be able to cough and clear their secretions, and they have to have an intact swallow, all right? If both of those things are good, you can decannulate. Stay with me, Matea. When you decannulate, you drop the cuff, you remove the trach, it does not get stitched closed, the stoma. You just put a gauze over it, a little antibiotic and gauze. And within 24 hours, that trach will be almost closed. Within 48, it's closed, okay? All right, okay. Now, if somebody doesn't pass that swallow study, or you're a little unsure whether they're gonna make it, how long did I say it would take that stomacite to close? Yeah, you can put in what we call a tracheal button, okay? Tracheal button, you guys share. All right, so the tracheal button keeps the stomacite open so that if the thing doesn't close if you're not sure. So you take the trach out, you put in this tracheal button, the back of it sits right against the trachea. Is there any resistance to inspiration?
No.
No. And you see this cap that's on the end there?
Yeah.
If you had the suction, you could pull the cap off and go down with a suction catheter, but it keeps the stomacite open. So the board loves to ask the question, what can you put in a patient that causes the least resistance but maintains the stomacite? It's the tracheal button. If the patient does well for 24 to 48 hours with the button in, then you can pull it out. If they're able to clear their secretion. So if you have any doubts, and you feel like you may have to access the trachea or put the trach back in, you put a tracheal button in, and then you just take that out and put the trach back in, or you can suction. Okay, so that's the purpose of the tracheal button. So you would measure that. So in other words, this goes in, okay? What you need to do is measure how far, so this goes again, so in other words, it would go in, here's my trachea. So this goes in that and hits that, the wall of the trachea, gets caught on the wall of the trachea. This goes against the outside skin. So you're measuring, so this is what's in the patient from here to here. Okay, everybody got that? This cap can be taken off and you can suction through there if you need to. Okay? All right.
Do you guys use those at hospital center?
I've seen them before, but their big thing is to downsize with smaller and smaller metal trachs, and then they just decide when to take the trach out or not. So I've seen buttons, but not that much in my last probably few years. Did you use buttons?
No, we never do.
Well, the other thing is, I was gonna say, how often were you out on the floors?
All the time.
Okay, I don't know why I mean.
We had
that's-
passing mirrors, we never had buttons.
Oh, yeah, passing gears, the talking valves, but
Yeah.
those go on top of a trach. They don't go.
Right.
This is not like this. You have
Right.
your trach in.
Yeah, we would just take it out.
Okay, all right. So that saves your stomacite, because your trach closes within a 24-hour period to 48, all right? Okay. All right, okay. There's one more thing that can go on a trach tube. It kind of acts like a fenestrated trach. Oh, I don't have the passing.
You have a
mirror.
passing mirror?
I have it back there, but this is a passing mirror valve, okay? These can go on a regular trach with a cup, all right? The patient's off the vent, but the trach is in place. You want to let them get used to talking. That's what this is for. So what you do is you, on inspiration, okay, so here's the trach. All right? The passing mirror goes right on the outside of the trach. So, when they inhale, the air goes in through the passing mirror. There's a one-way valve, but when they exhale, the air goes out the upper airway, okay? Because it only moves in one direction. So again, it's like the fenestrated trach. It pushes air up through the vocal cords. And so they vibrate and they can talk. Now, the trick question here is again with the same thing as the button on the fenestrated trach. you have to make sure you suction the patient, and the trach balloon needs to be deflated before you put this valve on. Because once this valve is on, just like the button, only with the button, when they inhale and exhale, it's all going through the mouth. With the passing urine, inhalation is through the passing urine, exhalation is up and out through the mouth, and that's how they can talk, okay? I do have a button, you want?
For a passing mirror?
Yeah, I have one out there so that they can see it, okay? And the last thing, I'll show you the passing mirror. Okay, oh, here it is, Joni, there's a picture of it here.
You got it?
Oh, you have it? Yeah, there's a picture of it here. Okay, so that little passing mirror goes right on the outside of the trach, but you don't put that on until you've deflated the cuff. Why? Because when they inhale, which way is air gonna go?
Let's go down
Through the passing urine. And when they exhale, which way is it gonna go?
to the
Out
mouth.
through the mouth. So you suction, you deflate the cuff, and then you attach the passing urine valve. Okay? The last tube to talk about is called the laryngectomy tube. You won't be putting these in or out. You may be taking care of patients that have laryngeal cancer. Okay, so if somebody has laryngeal cancer, they do surgery called the laryngectomy. What does that mean?
Cutting out.
They take out the larynx. The larynx is the connection between the upper airway and the lower airway, right?
Yeah.
So if they take out the connection, there's no more connection between the upper and the lower airway. They take out the trachea and they bring the trachea through a stoma. Okay, so why won't this work? Now I can't get this thing working, no. Okay, so, all right, so here is a normal patient. Here's the upper airway, guys. Can you see my mouse?
Mm-hmm.
Okay, there's the pharynx going down.
The larynx.
Here is the trachea, okay? The larynx is here. What happens if you have laryngeal CA and they have to take out the larynx? Here's your upper airway, go down, okay? Oop, there's no connection to the trachea, okay? So they take the trachea and they bring it out through a little hole in your neck. Everybody with me? Okay, so, if this person had to go on a ventilator, could you intubate them through the nose or the mouth? No, because there's no larynx and there's no connection to the trachea. So you would have to put an ET tube in or a trach tube in through the stoma site, okay? All right, so, the laryngectomy tubes, right after somebody has surgery, they want to maintain that stoma site for about 6 weeks, okay? So they put in what they call a little short laryngectomy tube until the stoma heals. Then they can take it out and those people have a permanent stoma, open hole, okay? So the laryngectomy tube maintains a patent airway. There's no cuff on it, okay? It's inserted in and in about 3 to 6 weeks it's taken out and this is what it looks like. Just a hole, the trachea is pulled up and attached to the stoma. Okay, they can eat.
They never talk?
They have that vibrator.
They have little vibrators that they can put by their,
Oh my God.
that measures vibrations.
Have you ever heard anybody use one of those phonations? And they put it up and they say, and it sounds like, what are you doing? You never heard that?
I think I see it in a movie or something.
Yeah.
Yeah,
Okay, right, the smoking, yes.
so here they can eat, food goes down the esophagus, but their air intake is through that stoma site, okay? So the laryngectomy tubes are used post-operatively. Got it? Until that stoma site heals. And the key is, on the boards, you could be taking care of a laryngectomy patient, they wanna make sure that you know that there's no connection between the upper and lower airway, and so when they say the patient needs to go on a ventilator, one of the selections may be intubate oro with an oral tube, intubate with a nasal tube, you cannot pick those because you can't use that. Put an ET tube in through the stomach, yes, that is what you would do. Okay? And that's the end. I know there's a lot of airways, especially towards the end, okay, with the buttons and the passing ear valves. Joni, what you got there?
I've got directions on how to do the